So we're going to talk about alphas and what we need to do in terms of looking forward in therapies. Some of these already started like radium and others are on their way like actinium. So let's see what we've got today. Oops. So just make sure you remember to mute yourself. Two more people in the room. So generally, nuclear medicine therapy has been based on beta emitters. They've got a range of about 0.1 to 10 millimeters, 0.1 for P32, 10 millimeters for yttrium. And they deliver most of their energy at the end of their path length.
Because I get that maybe you are a little bit short and maybe you are not too well. So
okay, just try and get. Let's try again to mute everybody. That should work. So we're going to get everybody's discussion. So alpha emitters are a helium nucleus. They consist of 2 protons and 2 neutrons. They have a positive charge of 2+, and they're emitted from protein-rich radioisotopes effectively. Their penetration is much smaller. It's between 0.001 to 0.01 millimeters, which is between about 1 and 4 cells. But within that, they can give off a significant amount of energy. And to be honest, not really much can survive a beta emission, an alpha emission. Unlike beta, where there's quite a lot of repair mechanisms, the destruction to the cell created by the alpha is quite significant. So moving to alphas, they can be very effective in tumor kill. Also, they have multiple radioactive daughters. So from one atom of an alpha emitter, you can get several decays. So you get a lot more alphas and betas coming off. They're relatively easy in terms of radiation protection because a plastic syringe is a very good shield. But they can be very toxic in the wrong position. As you know, in London, we had a Russian dissident who was killed by poisoning with alpha emitters. And as a consequence, we need to be very precise targeting. So you need to be absolutely sure that your product is going to target your tumor that you want to treat, because otherwise you'll end up with quite a lot of toxicity. The chemistry may be complex because of these very intricate decay mechanisms. So you don't want, for example, if you give actinium, that to be fine, but one of the daughters to then disassociate and go out of the target cell. So those of you who want to know, the mass is 6.7 by 10 to the minus 27 grams, and it has a charge of 1.6 times 10 to the minus coulombs. And effectively, this results in a radiation energy of about 1,000 times greater than the beta electron. As we said before, if you've got to get good targeting, but it's easy to shield. So this is a little cartoon that was produced by the Bayer company for their radium product. And it tries to show the difference between betas and alphas. And if you get very good targeting, so for example, here, the white area is meant to be the bone, the pink area, the bone marrow. And they're basically showing that with a beta, when you have got attached to the bone next to the metastasis, then you are still irradiating quite a lot of bone marrow. But with the alpha, very little normal bone marrow gets irradiated because the path length is so short. In terms of shielding, Ernest Rutherford, who did most of the work on the discovery of alphas in the 1890s, said that if you fired an alpha ray at a piece of toilet paper, it would bounce off. Now, I would have to say this, that 1890 toilet paper is a bit thicker than present toilet paper. So maybe you'd need a couple of sheets of 2021 toilet paper to get the same answer. So as you know, with betas, we have to use things like Perspex, and for gammas, lead. But for alphas, we can shield with just a normal syringe. It normally shields perfectly well. So I keep repeating this, but we do need to have good targeting. And we need to have a high affinity for that target and stability at the target as well. And then anything that's not on the target, we do need to clear rapidly. It's useful if there's a gamma emission somewhere along the way, because then we can use that for biodistribution and dosimetry data. And we want it to penetrate the tumor. So it's no good if it's only just in one part of the tumor. It needs to penetrate the whole tumor. So this is the decay, a fairly simple decay. This is a bismuth-213, which is an alpha emitter, and it has two paths to go. It can either go to thallium-209, then down to lead-209, and then bismuth-209. And that way you get one alpha and two betas. But in fact, that's not the most common pathway. The most common pathway is first a beta emission to polonium-213, and then an alpha decay down to lead, and then to bismuth. However, that's a fairly simple one. This is even more complex one. So you can start off with actinium-225, and that gives you one alpha down to francium-221. Then that decays down to actinium-217, and then down to bismuth-213, then back to that original pathway. So if you're giving somebody actinium-225, then you can get 1, 2, 3, 4 alphas and a beta. So you're getting all these different alphas being produced. You'll notice that the atomic weight drops by 4 for each decay, because obviously the atomic weight of an alpha is 4. So the first that came commercially available was radium-223. It's a group 2 element, so it has similar chemistry to calcium, and it provides good targeting to bone around metastasis. And effectively, the ratio in the bone next to metastasis is about 10 times normal bone. And it had good results in clinical trials, but obviously it can only treat bone metastasis. So here we have radium sitting underneath calcium as a group 2 metal, and the body treats it very much as a group 2 metal. So it is actually any radium that the patient has either medically or ingests gets absorbed into bone. And you'll notice also strontium is on that list, and strontium has a beta-emitting strontium-89, which is also used. So just to remind us of the natural history of prostate cancer, you tend to get slightly rise PSA, and then you get the initial diagnosis and the patient gets treated. And then the PSA rises again, so then they get a chemical castration. And then it may be many years, or it may be months, and then it escapes castration known as castrate-resistant prostate cancer, or CRPC. And this tends to involves then getting metastasis, and then it gets serious events from that, the SREs, and then death. So we are intervening in this area here, and that's true with the PSMA as well. So just a little bit more about castrate-resistant prostate cancer. They have to have been treated with a reasonable amount of castrate resistance to drop their testosterone levels down to less than 50 nanograms per deciliter. And they're looking for 3 consecutive rises in PSA, at least 1 week apart. And a PSA rise of more than 50% of baseline is normally considered the positive. Some of these are still hormone sensitive, so they might be able to have certain hormones which may affect it, but generally, by the time we see them, they've already had their abiraterone or enzalutamide. And so despite all these very clever and expensive hormonal manipulations, they can still have progression. And that may be seen as a rise of PSA, but also the start of seeing bone lesions and possibly soft tissue disease as well. So these are some recent studies that weren't anything to do with radium, but this is just some studies that were performed in Europe on patients actually being treated with chemotherapy, and they were looking at the incidence of bone metastasis. And in all these big studies, and they all had over 1,000 patients, except for one study at the bottom, almost all of them showed that around about 90% of patients have bone metastasis. So bone metastasis is very common. And we know that because we do bone scans, and we do them on a regular basis. And here's a bone scan of a patient who has multiple bone metastasis. Not surprising, this patient may well be the kind of patient we would consider, for example, radium, but obviously they have soft tissue disease, we may have to move down the PSMA path. Now, there is an X-ray that's released by Radium-223, and this can be seen. So the top one is a bone scan of a patient who has a nasty expansive bone met in a rib, and this is the radium gamma image. It's not such a good image, but you can see that the uptake is very similar. There is one difference there, you'll notice, and there's gut excretion of the radium, but no gut excretion of the calcium. So again, we talk about complicated decay mechanisms. So here we have the decay mechanism for radium. So radium decays down to radon, which goes down to polonium, which goes to lead, and then to bismuth, then either to polonium or down to thallium and to lead. Now you may say, I've seen some of this before, but remember that was bismuth 213, this is bismuth 211, and we had thallium 209, this is thallium 207. But some of these have got very short half-lives. So whilst radium is 11 days, this radon is 4 seconds, this polonium is just under 2 milliseconds. This is slightly longer at 1 minute, and then 2 minutes, and the polonium 215 has a half-life of half a second. So it actually doesn't take that long to get from the radium down to stable lead. Probably on average no more than 4 or 5 minutes, but during that you can get 1, 2, 3, 4 alphas and 2 betas. So the results which led to it being accepted as treatment was the Alsympca study. And this was a study of nearly 1,000 patients, and they were randomized to 2 different groups. So these are patients who had castrate-resistant prostate cancer, and they were either given Radium-223 at what was then a dose of 50 kilobecquerels per kilogram. We now use 55 because we understand that it's easier. There was a mistake in the way that the calibration was made, so we were under treating people. And they would have 6 injections at 4 weekly intervals, plus any best standard of care. The rest would also have injections, but they would just contain saline and best standard of care. And best standard of care could not include taxane chemotherapy. However, patients were allowed to be included in the trial if they had had previous taxanes, and they were allowed to have bisphosphonates. Bisphosphonates don't really affect the uptake of radium into the bone. So this is the results of the Kaplan-Meier curves of overall survival, and you may well have seen these in other talks and maybe probably talks I've given. And you can see the median overall survival for the patients that were treated with radium was nearly 15 months, and it was 11 months for patients with placebo. Now that's very similar to what we saw, interesting, with the PSMA in the VISION trial, but that was a significant difference, and that led to authorization by the FDA and European Medicines Agency, etc. And then again, they did a sub-analysis, and this was all published in the New England Journal of Medicine by Strasberg, and you can see here, sorry, not Sartor, not Strasberg, and we can see here that generally, again, if you're this side of the line, then radium is good for you. If that side of the line, the placebo is better. And the only patients who really did badly were those who were very poorly to start with a poor performance status. The number of metastases, interestingly, if you had very few metastases, then the radium didn't make much difference. And that's probably because the disease hasn't really been that extensive or metastatic. And so we have a general rule that you have to have at least 6 bone metastases before you get radium. So new bone pain, again, there was a significant difference between the patients on radium and placebo. And we find very quickly patients get pain relief with this treatment, though it's primarily done to try and increase survival. And so the median time to the first symptomatic in the skeleton, which is normally bone pain, was 15.5 months compared to 10 months on the placebo. So there was a significant improvement in all the measurements they were making in terms of bone pain and survival. But the one thing that didn't change very much was PSA. And nobody really understands this. And they actually have patients who've almost been cleared of tumor, but still have an elevated PSA. And it's thought that it's so destructive. In fact, what happens is that a lot of the prostate cells are just destroyed and they release PSA. And if you measure it about 4 months after the last treatment, they can then fall. Adverse events, interestingly, we thought that the most significant problem would be in the bone marrow, because obviously you've got alpha emitters in the bone marrow, but that didn't prove to be the case. In fact, the patients generally did as well as the placebo group, and that's partly because they didn't have tumor growing and gnawing through their bone marrow as the placebo people did. The only real one which was a significant difference was some patients got an increase in bone pain, and that was normally 10 days post-treatment, and that's a kind of flare reaction that's related to the treatment working. And we found that most people that had that flare reaction then went on to have a very good pain relief that was substantial. And then it's some GI type things, diarrhea, etc. And that was mainly very mild. So if you look here, 25% of patients had diarrhea with the radium versus 15 without, and that was significant. And if that's a problem, we just give your patient some loperamide. So what about practical points? You need to check the patient is eligible, and that's done with a bone scan, and make sure they don't have significant soft tissue disease. That might be done with a PSMA study or a CT or an MR. So we obviously need to have a recent bone scan, and also we need to demonstrate that it's not responding to either castration or chemotherapy. Now you need to have reasonable bone marrow function. Now all these patients tend to be chronically anemic, these prostate cancer patients, because they've had all these other treatments. So except a hemoglobin, it used to be called 10, I think it's now 100, platelets 150 and white cells of 1. If you think there's a fracture risk, then you may need to fix that first, and particularly be very wary of vertebral fractures. And as I said, no bulky soft tissue mets. So this is one of our patients in June 2016 with multiple mets in the spine. And here we are in January 2017. And there's still a couple of mets left, but there has been general improvement in the number of metastases. And this was our results also in our hospital of patients who were able to complete all 6 treatments versus those that weren't. So if you weren't able to complete all 6 treatments, your median overall survival was around about 15 months, slightly better than in the clinical trial. But if you were able to complete, then it was much, much better. It was a couple of years median survival. Well, that's all well and good, but as we know, some patients have soft tissue disease. And as we heard yesterday in our question and answer session, sometimes the lutetium works very well, but it doesn't stay working and the tumor comes back again. And this may just be because it's a fast growing tumor, it's more aggressive, and so we need to hit it a bit harder. So this was the Heidelberg group's answer to this, and this was to use actinium-225. And they just treated with a fairly small amount, 100 kilobecquerels per kilogram every 2 months, and they showed a good response. But whilst they had no bone marrow toxicity, they had quite significant dry mouth xerostoma, which didn't really recover. And here we have one of their patients, and they've got very bulky disease. They were given 2 cycles of 225 actinium, and the disease disappeared, and the PSA returned to normal. I think that's still probably one of their best ones. This is one of Professor Satege's patients from Pretoria. This is actually with bismuth, but again, bismuth, as you know you saw from the decay, is sort of halfway down the decay, so you're still getting a couple of alphas there. And you can see that originally there was a lot of disease in the abdomen on the PSMA study. Again, after treatment, there's not a total reduction of the PSA, but it's certainly reduced quite a lot. And on the PSMA scan, you see hardly any evidence of disease. So these things can work. And a couple of years ago, the Pretoria group did actually look at a group of 17 chemo-naive patients. They gave them 3 cycles, and the idea was to give a higher activity to start with, and then less and less, because the theory being is there's less tumor, so you need to give less, and that helps with your toxicity. And almost all the patients, all but one patient, showed a PSA response, and 14 of those patients, it was a greater than 90% drop. And 15 out of 17, so that's probably a good 90%, showed a greater than 50% decrease in lesions on the gallium PSMA PET scan. But again, they did show there was some toxicity. In this case, bone marrow, one patient had renal toxicity, but they only had a single kidney. And obviously they still had the problem with the dry mouth xerostoma. So looking at this study in a little bit more detail, this is the waterfall plot. And if you remember, you plot the maximum change at this end and the maximum change up at this end in this particular plot. And these are all the different patients. And you can see this was the response at 8 weeks after the first cycle. This is the response at best response at any point. And you can see that for the majority of patients, they pretty well at some point achieve a very, very good response with very little PSA left. And this is from their paper, and it shows a patient with multiple lesions, and the PSA was 6.7. They then were treated and it went back to normal. The PSA rose a little bit in November, retreated with the actinium, and it got better. And then they continued to treat with actinium and it stayed down. So this patient has significant bone marrow disease. Almost every bone is involved. So this is a patient you may think, oh no, if we treat them, they'll have bone marrow toxicity, but it was all manageable. And they went from an initial PSA of 762 on the second PSMA scan in September 2017. There's a significant reduction in disease load. Almost all the bone mets seem to have settled, and the PSA is heading down. They then have a third PSMA scan before their next treatment, and the PSA is now less than 1. Then after the third treatment, it drops down to 0.07. So, but the interesting thing is that a few months later, it still stays down, and we don't always see that with lutetium. So certainly actinium is a very interesting agent to use. And the question is, how will it stack up in a clinical trial situation? And I think the main thing is we need to do is learn how to control the toxicity, particularly to the salivary glands. This is looking at the average in hematological counts. So here we got the white cell count and the hemoglobin, and they are reduced a bit, but they're actually not significantly changed, even though they're down a bit. Serum creatinine rises slightly, which reflects possibly a little bit of renal damage, but serum albumin remains the same, so the liver is not affected. So that's alphas and PSMA, and if you need any more information, please read the papers that came from Pretoria. So the last thing we're going to talk about is radioactive pastes in skin cancers. This is something that's fairly new and is becoming more widely available. And the reason it may be important is because of the incidence of these cancers in certain populations in South Africa. And these are looking at non-melanoma skin cancers. And what effectively you do is you put a plastic barrier down, and then on top of that, you put a rhenium paste over either an SCC or BCC, and you calculate how long you need to be on that site to give the right radiation dose, which depends on the size of the lesion and its depth. And it's a very simple way to deliver a radioisotopic treatment. And then when you've finished, you just take the plastic sheet away. And by plastic sheet, we mean something like one of these op sites that you can get for putting on cannula. So they come in these things called carpools, which is really basically a lead shielded arrangement where you have the paste and then you pull up the paste with your brush, and then you use your brush holding onto the shield to then paint over where the lesion is. Well, you draw around the lesion and then you put the plastic sheet over and then you put the paint on. And these are the bits of arrangement that are put in. So you've got a measuring station, you've got a storage station and a waste station. These are all fairly bulky, unfortunately. So you can see here that this is a patient who has got a SCC on their cheek. So this is maybe somebody who, as you know, pale skin people don't do terribly well in strong sunlight. So this is a classical place on the cheek. And then what's happened is the plastic sheet's been put on, it's been drawn around the edge. And then this paint, which comes out as a silver color, is just painted on. So it's a very thin layer of the radium. And that will then irradiate down through the tumor. And what you're trying to do is avoid irradiating the hypodermis, because that will enable the area to heal. And here we are a couple of months later, and the tumor's gone and the skin has all healed up. And this is much better than multiple surgeries. So how do we do it? This is a slide that's been provided by the company, is that you define, you clean the area, you define it, you put this plastic little sheety thing on, which you can see it better in this picture. You can see this little plastic sheet. They call it a foil, but it's actually a sheet. So you put on the foil and you can see through, oh, sorry, this thing keeps moving. You can see through it where you've measured your little dots, and then you put on, using your carpole and your brush, you put on the Rhenium, and you've calculated how much activity you've got and how much time it requires to be on. And this may be anything from 20 or 30 minutes to maybe an hour or two, depending on the depth of the tumor. And then you just remove this foil or plastic sheet, I think I call it a plastic sheet, and you just dispose of it in radioactive waste. And that's it all done. And there's no actual radioactivity of substance touches the patient, because you have this protective foil in between. Now we'll get to this one. So these are some publications, and looking at single therapy remissions. So this is, they may have to have multiple treatments. They get multiple SCCs or BCC, but each of them only needs one treatment. And this was published by Cipriano in Italy. And you can see here that a significant number of patients were having very good treatments. With a single treatment, you got 86%. And there were just 14% of patients who needed a sort of retreatment. So 86% of all patients could get away with a single treatment, 2 treatments in 14%. One patient had 27 lesions treated. Some patients have multiple BCCs over hands and face. The oldest patient was 105 years. And of course, otherwise they're perfectly well. They're just daycare patients. And no side effects were reported, though you do need to look after the site which has been treated, because it will become quite sore and uncomfortable, and it needs to just be kept clean with dry dressing, etc. And the other thing is that as far as we know, at least up to 5 years, or probably 6, you don't get any recurrence at the site which you've treated, which is extremely good. So this is another paper that's just been published as well, looking at using these Rhenium creams. And they looked at 50 patients aged 57 to 97, because it's a disease of old people. And they looked at 60 non-melanoma skin cancers that they treated. And the target dose was about 30 gray. And in all patients that they could evaluate, there was complete removal at 12 months. There was one patient who relapsed at 2 years. There was some early side effects, normally just redness and sometimes some sloughing of the where the site of the tumor is, but there is often very rapid regrowth of skin and healing, and patients didn't really have persistent problems with, for example, skin ulceration. So it does seem to be very safe. And again, the people at Pretoria have had some experience with this. So this is an example. So here we have a BCC, and it should just work through. And this is the healing process that you get. So what you do see is you see some, after you treated it, you may see some redness, some soreness, some desquamation, but then eventually you get skin healing. The interesting thing is that often these areas are non-pigmented. And this is a BCC on the forehead. And again, you can see there's some sort of sloughing the skin, and all you need to do is just protect the area with a dry dressing to keep it clean. And then again, you get a very good cosmetic result. And by 11 months, you'd need to be the person who actually treated it or the patient to know which way the treatment was. So in conclusion, not only of this lecture, but of this series, alpha emitters have arrived. We need to find new ways to handle them, but they can be very safe. We need to find ways of targeting very effectively and try and reduce activity in organs we don't want to treat. It opens up a whole new set of opportunities and can expand nuclear medicine therapy maybe into new fields, because we might be able to treat more aggressive tumors. And topical radionuclides can be used in skin cancers. And this Rhenium paste is probably the first of many that we might get. So thank you very much, everybody.